Okay, a pleasant day, dear doctors, for those who are watching online, for those who are in their respective institutions, for those who are at the comfort of their home or a coffee shop, listening in to this session. So I'm going to give you a high yield module, which will be divided into two. This will be the first module, and this is about a very important topic, which is the intracranial neoplasms and the paraneoplastic disorders. So in simple layman's terms, we're going to talk about the brain tumors. So this is Dr. Toom, and thank you for taking time to listen. So these are the following references which I will be using for this high yield module. So the first and foremost materials which we are going to use is one of the Bibles of adult neurology, and that is Adams and Victor's Principles of Neurology. I will be inserting some very important clinical pearls as well as some pathophysiologic must-knows about the manifestations lifted from Harrison's Principles of Internal Medicine. A lot of the topics or the chapters which are in Harrison's Principles of Internal Medicine are actually from the same authors who contributed to the chapters in Adams and Victor's Principles of Neurology. So I do invite you to read this from your actual textbook, particularly Adams Neurology. And this is chapter 31, which is entitled The Intracranial Neoplasms and the Paraneoplastic Disorders. Now, I'd like to share with you that the name of my dog, okay, the name of my beagle is actually Adams. Okay, so the name of my dog is Adams. Now, this is basically the first thing we have to know when we talk about the intracranial neoplasms. The intracranial neoplasms are divided into either a primary intracranial neoplasm or a secondary intracranial neoplasm. Now, when we say primary intracranial neoplasm, this is a brain tumor that arises within the central nervous system. So if you remember, the central nervous system is the brain, okay, and the spinal cord. So any tumor which arises from the cells of the brain or the spinal cord is a primary neoplasm. Now, they can either arise from the glial cells, which I will expound deeper in a while, the oligodendrocytes, the meningothelial cells, the ependymal cells, and the Schwann cells. Now, can anyone tell me what important phospholipid is produced by the oligodendrocytes? Can you type in your answers in the chat box or in the comment? What important lipid is produced by the oligodendrocytes? So what is produced is the myelin sheath. The myelin sheath is produced by the oligodendrocytes. In fact, the oligodendrocytes are the cells that produce myelin sheath in the central nervous system. The Schwann cells, on the other hand, are the major cells that produces the myelin sheath in the peripheral nervous system. Now, for the secondary intracranial neoplasms, these are the neoplasms that do not arise within the central nervous system. They originate from outside. And most cases, that is going to be metastasis. So it comes from a primary cancer or a primary neoplasm, okay? A primary cancer or a primary neoplasm that arises from a different organ and it metastasizes or it spreads to the brain. Now, question. What is more common, Is it a primary or a secondary neoplasm? Okay, let's see your answers. Please type in the chat box. What do you think is more common? Is it a primary intracranial neoplasm or secondary intracranial neoplasm? Now, always remember the most common brain tumor is from metastasis. Okay, so metastasis is more common than a primary brain tumor. Now, as mentioned earlier, primary tumors originate from or within the CNS, while the secondary, which we refer to as the metastatic tumors, okay, they originate from the cells outside of the CNS. Now, metastatic tumors are more common in adults, while primary tumors are the most common solid tumors in children. Now, I will expound in a while. Okay, I will expound in a while what is the significance of this epidemiology and prevalence, because there are certain tumors which most likely will be encountered in an adult, certain tumors which will most likely be encountered in a child or the pediatric age group. Okay, so here, according to our textbook, in adults, okay, metastatic or secondary tumors are more common. In children, primary brain tumors are more common. Now, if you remember your basic anatomy, okay, now I think I have a brain here next to me. So here, I hope you guys can see this, okay. Do you see this brain here? Now look, okay, so let me rotate this brain. So this is the frontal lobe, okay. This is the temporoparietal, this is the right side. Let me rotate, this is the left, okay. The green, this is the cerebellum, and of course we have the brainstem. So if we hold it like that, we have a very important structure, which we call the tentorium cerebelli. It's the tent-like structure which separates the cerebellum from the cerebrum. So why is the tentorium cerebelli important? All of the structures above the tentorium cerebelli are referred to as supratentorial. All of the structures, okay, all of the structures which are found below the tentorium, we call them infratentorial. Now, why is this important? Because brain tumors in children are usually infratentorial. Memorize that. In adults, it is usually supratentorial. Okay, now what are the infratentorial structures? So in the infratentorial structures, we have the brainstem. Okay, so you're going to have the midbrain. Okay, you're going to have the pons. You're going to have the medulla. And of course, we have the cerebellum. So most children have tumors which are infratentorial in origin. But you have to remember, you can also see infratentorial tumors in adults, but it's more common in children, okay? So please remember that pearl. Now, here is a table which shows us the age-specific frequency of the tumor types. So as you can see, in childhood, what we usually encounter in childhood are neuroepithelial tumors or tumors of glial origin. The most common of the glial tumors in children is going to be the pilocytic astrocytoma. In adults, it's more or less split into either a glioblastoma, okay, a glioblastoma, or meningeal tumors. And the most common meningeal tumor you're going to encounter in adults is going to be a meningioma. And as the patient gets older, there's going to be a higher possibility it's going to be a meningioma. Okay. Now, I would like to share this summary about the metastatic brain tumors. These are the most common primary brain tumors that will metastasize to the brain. We have lung cancer, breast cancer, skin or melanoma, kidney or renal cell cancer. Then we have the gastrointestinal tract, for example, and in particular, colon carcinoma. So what are the most common primary cancers that would metastasize to the brain? Lung, breast, skin, which is melanoma, kidney, which is renal cell CA, and gastrointestinal tract, which is colon CA. So why is this important? If you are the physician who discovers that a patient has a CT scan or an MRI, let's say this is the scan, and there's multiple brain tumors. Multiple brain tumors would most likely be metastatic rather than primary. Most primary brain tumors will be solitary. That means siya lang isa. If you see multiple, that raises the suspicion that this is most likely metastatic until proven otherwise. So let's say you discover someone with an imaging study, let it be a CAT scan or an MRI that has multiple brain tumors. You have to work up the patient for possible lung cancer. You might want to ask, okay, history-wise, is this patient a smoker? Does the patient have a family history? Does the patient have headaches? Okay. Now for breast cancer, you would have to do a breast exam. Okay. Ask for a family history of breast CA. Palpate the breasts. Palpate the axillary lymph nodes. Okay. For the skin and melanoma, you look for a nevus, particularly, okay, the famous precursor. Okay, the precursor is what we call a dysplastic nevus. Or if someone has a mole that shows letter A, asymmetry, letter B, irregular borders, letter C has a change in color, D, a change in the diameter. You have a rapidly increasing or an increasing in size mole, the ABCDs. These raise the possibility that you might be dealing with a melanoma. Okay. Then, of course, for renal cell CA, what we ask for in the history is the triad of renal cell CA. You're going to ask for the painless hematuria, okay, the flank pain, and an abdominal mass. For the colon CA, you would have to ask in the history for bowel changes, okay, weight loss. So you might ask for hematochezia, okay, melena. So these are just the things that you, as a sound physician, has to investigate. Okay, so it's like you're moving backwards, investigating. You have a patient who came in for seizures or headache. When you did the CAT scan or the MRI, there was multiple tumors. Oh, this might be metastatic brain cancer. So I need to go over history very well, do a complete, not only neurologic, but also general physical exam. Then you start the workup. Okay, so I hope everyone got this picture. Now, I want to share this mnemonics with you. Lots of bad stuff kills glia. Okay, again, lots of bad stuff kills glia. So L, that's for the lung. B, that's for the breast. S is for the skin, which refers to melanoma. K is for kidney cancer. G is for GI cancer. In descending order, these are the primary neoplasms or cancers that usually metastasizes to the brain. The most common is lung cancer. Okay, so please remember this. Now, I would like to share with you that there are some primary intracranial as well as primary spinal tumors that have a disposition to grow in particular parts of the cranial cavity. Why? I would like to share with you these three tumors. This is a very important clinical pearl. Number one is craniopharyngioma. Number two is meningioma. Three is schwannoma. Now, I want to share with everyone that craniopharyngiomas are usually found in the sellar area. Okay, so it's near the sella turcica. Now, can anyone here type in what important endocrine organ is near the sella turcica? Okay, what important endocrine organ is near the area of the sella turcica? Okay, what is that endocrine tumor or endocrine gland? It is the pituitary gland. Okay, the pituitary is lodged in the sella turcica. Okay, so I want you to remember this because craniopharyngiomas are usually seen in children. In adults, the pituitary tumor that you're going to see is most likely going to be a prolactinoma until proven otherwise. Now, for the meningiomas, okay, most meningiomas arise from the arachnoidal cap cells. The meningiomas are usually extradural, okay, or extraaxial. Extradural, extraaxial, they are usually going to be found in the sagittal or parasagittal area. They are usually also found, okay, near the tentorium, near the falx, okay? So these are the usual areas where meningiomas are found. Now, what about a schwannoma? A schwannoma is classically found particularly in the cerebellopontine angle, the famous CP angle. Now, can anyone tell me in basic neuroanatomy, what are the cranial nerves which can be found in the cerebellopontine angle? What are the cranial nerves that can be found in the cerebellopontine angle? So number one, we have the facial nerve. Okay, that's cranial nerve number 7. We also have the vestibulocochlear or the 8th cranial nerve. So cranial nerve number 8 is there. So what can the patient present with? The patient can present with hearing problems or tinnitus. They can also present with facial palsy. And since it's near the cerebellum, if the mass is big enough to compress the cerebellum, they can also present with symptoms like imbalanced gait ataxia. Okay, so this shows you that there are particular tumors which grow in particular areas. You can also see schwannomas. Okay, in the spinal cord, okay? Now, there are also tumors associated with disease conditions. So here, you have an acoustic schwannoma. Here's the vestibulocochlear nerve, which is cranial nerve number 8. So there can be hearing loss. Tinnitus. This is what we call neurofibromatosis. Now, neurofibromatosis, there's 2. There's neurofibromatosis 1. There's neurofibromatosis 2. Now, I'd like to share a very important memory tip with you. NF1, this is known as von Recklinghausen's disease. Now, if you spell von Recklinghausen's, there is 17 letters. So this affects chromosome 17, especially the long arm of chromosome 17. So you get multiple neurofibromas, and it is the NF2, okay? The NF2 is the one that is associated with bilateral acoustic schwannomas, okay? It's also associated with meningiomas. So this shows you that there are certain disease conditions which are associated with brain tumors. So neurofibromatosis 2. Now, another example is AIDS. Patients with AIDS have a predilection for developing CNS lymphoma. Okay, CNS lymphoma, especially the B type. Okay, so please take note of that. Now, I failed to mention this earlier. We have what we call neurocutaneous syndromes. These are diseases that present with dermatologic or cutaneous or skin manifestations, and it's associated with a neurologic condition. For example, brain tumors. So earlier, NF1 or von Recklinghausen's disease, this is associated with tumors, but it's more associated with NF2. We also have a condition known as tuberous sclerosis. This is a neurocutaneous syndrome, which is associated with dermatologic manifestations like an ash leaf spot. It's also associated with another lesion called sebaceum adeneum. Okay, and this is also associated with neurocutaneous syndromes. Okay, like a shagreen patch. Okay, so these are the dermatologic manifestations. Now, why is this important? Because tuberous sclerosis is associated with tubers or brain tumors. Okay, it is associated with brain tumors. I'm not sure if you're aware of another condition which presents with a hemangioma on the face. So we have what we call the port wine stain. Now, can anyone tell me what brain tumor is associated, what syndrome this is? You have a hemangioma on the face, which is known as a port wine stain, and they also have an association with brain tumors. Now, this is called what syndrome? Okay, this is known as Sturge-Weber syndrome. So please make sure you jot these things down. Okay. So please make sure you jot these things down. The neurocutaneous syndromes. Now, another principle I want to share with you, which is discussed in our textbook, is that the growth rates and the invasiveness of tumors actually vary. In other words, the behavior, the aggressiveness, the invasiveness, the growth of a tumor differentiates. Why? A glioblastoma multiforme, which we commonly refer to as GBM, is highly malignant, it is highly invasive, and it is rapidly progressive. In other words, this tumor has a poor prognosis. What is very challenging for us neurologists and neurosurgeons is that GBM is actually the most common primary brain tumor in adults. Siya yung most common, siya yung poor prognosis. So it's not good. This is opposite to the meningioma, which is considered to be the most common benign primary brain tumor in adults. So always remember, meningiomas are benign. They are slowly progressive. They grow very slowly. However, they can compress, okay? They can compress surrounding intracranial structures, cause edema, cause increased intracranial pressure. So remember this, meningioma is mabait, okay? Dili maldito, okay? It is behaved. It is benign, okay? Glioblastoma, GBM, is grabe. Grabe, very malignant, very invasive, very rapidly progressive. Okay, so please remember that. So where do actually brain tumors arise from? Now, most primary brain tumors are glial cell in origin. And one of your common glias are the glial cell tumors, are the gliomas. They can also come from the astrocytes. That's why we call them astrocytomas. They can come from the oligodendrocytes. That's why we call the tumors oligodendroglioma. Then we have the ependymoma, which means ependymal cells. Now, I want you to remember ependymal cells are usually surrounding the spinal cord canal, and this is the basic epithelium which surrounds the ventricles. Okay, so I want you to jot that down. Spinal cord canal. And we have the tumors. Now, other brain tumors can arise from the lymphocytes, such as lymphoma. And we mentioned earlier the association of CNS lymphoma with patients with AIDS. Brain tumors can also arise from the precursor neuronal elements, such as the neuroblastoma and the medulloblastoma. They can also arise from the germ cells. That's why we have germinomas, teratomas, and craniopharyngiomas. And it can arise from the endocrine elements, such as a pituitary tumor. So don't forget your endocrine elements, that the anterior pituitary gland arises from the Rathke's pouch. It's the anterior pituitary gland. The posterior pituitary gland arises from the neuroectoderm. Hence, it's called the neural hypophysis, or the posterior pituitary gland. So I want you guys to take note of this. Now here's a table, okay, showing you the different types of intracranial tumors. Okay, so this is a study, okay, a very famous study which involved about 15,000 cases. So out of these 15,000 cases, the most common primary intracranial tumor is still the gliomas. Okay, most common of the gliomas is the GBM, okay, the glioblastoma multiforme. This is followed by the meningiomas. Okay, so that is your take home from, that's your take home from this table. Now in children, this is in adults, In children, it's the astrocytomas, which is more common. Okay, particularly pilocytic astrocytoma. The details of the specific tumors we will be discussing in the second part of this module. For now, we'll just talk about the basics. So for the classification and grading of nervous system tumors, okay, we usually base the classification on the presumed cell of origin of that neoplasm. So as mentioned earlier, if it comes from lymphocytes, it's lymphoma. Okay, if it comes from the oligodendrocytes, it's called an oligodendroglioma, and so on. So what is the purpose of this grading system? The grading systems are meant to be an estimate of the rate of growth, so the growth rate, as well as the clinical behavior. With the grading systems, we get a better understanding of the growth rate. We also get a better understanding of the clinical behavior, which is more rapidly growing, which is benign, which is slow growing, which is malignant, and so on. Now, according to the World Health Organization classification, we have grade 1, grade 2, grade 3, and grade 4. There are 4 classifications of the astrocytic tumors. Okay, so the grade 1, so take note of this, grade 1 are the pilocytic tumors. Okay, grade 2 are the diffuse, well-differentiated astrocytomas. Grade 3 are now the anaplastic. And grade 4 is the famous GBM, or the glioblastoma multiforme. Now, another means of classifying brain tumors, aside from the previous classification by the WHO, are based on the following parameters. So number 1, the degree of nuclear atypia, the cellularity, mitosis, vascular changes, and prognosis. So the classification of brain tumors based on the degree of nuclear atypia, cellularity, mitosis, vascular changes, and prognosis. So you will notice this classification of brain tumors is more of histologic microscopic. And based on the histology, okay, or the histopathology, then we get the prognosis. Now, for the glioblastomas, okay, I made a quick summary here of the most important pearls that you need to know as a student, as a clinician. So number 1 characteristic of glioblastomas is really the necrosis. Very aggressive, significant amount of necrosis. Next is the anaplasia. Third is the vascular proliferation. So repeat this to yourselves. The 3 most important characteristics of glioblastomas. Number 1, necrosis. Number 2, anaplasia. Number 3, vascular proliferation. Okay, necrosis, anaplasia, vascular proliferation. So necrosis, anaplasia, and vascular proliferation. Now here, this is a very busy table, okay? That's why this textbook is quite scary, to say the least. This shows you the main categories of WHO brain tumors. So please make sure you scan the actual book because these are must-knows. The main categories of the WHO tumor classification. So please take note of this. So first, you have there the astrocytic tumors, okay, oligodendroglial tumors, ependymal tumors. You have the mixed gliomas, okay, tumors of the choroid plexus, which of course produces the majority of the CSF. Then we have neuronal glial tumors, okay, and down the line, the pineal gland tumors and the tumors of the embryonal origin. This is where you see the medulloblastomas, the PNET, okay, the PNET. Then you have other CNS neoplasms based on region, so cellular, okay. Then you have the hematopoietic, which are the lymphomas. You have the germ cell tumors, tumors of the meninges, which number one on the list is meningioma, tumors of the cranial nerves and the spinal cord. You have tumors which are metastatic. Okay, so just familiarize. You don't have to memorize, just familiarize, okay? And make sure you check out this table from chapter 31 of the book. Okay, so here we mentioned the grade 1, grade 2, grade 3, grade 4. So don't forget, under grade 1, the astrocytic, particularly pilocytic astrocytoma, and the subependymal giant cell tumor, which we commonly call SEGA. Okay, that's the subependymal giant cell astrocytoma. So please take note of that. It's the only thing I want to highlight in this slide. Now, for the grade 1 astrocytomas, they are relatively benign. The pilocytic astrocytomas are well differentiated. We usually see them in the younger age group, so children and young adults. Now, I just want to mention the pilocytic. Pilo means hair, okay, hair-like structures. When you look in the microscope, you're going to see the hair-like structures, which is meaning pili or hair. Then we have the xantho astrocytoma. So from the prefix xantho, this is cells which are filled with fat or lipid. Then, of course, we mentioned the SEGA, subependymal giant cell astrocytoma. Okay, this is usually associated with tuberous sclerosis. You have to remember that in patients with tuberous sclerosis, aside that this is a neurocutaneous syndrome, as mentioned earlier, okay, they also have a high chance of developing a rhabdomyoma, so a cardiac tumor, okay? A lot of them would present also with a rhabdomyoma. And for the ependymomas, we basically divide them into three: myxopapillary, okay, the clear cell, and the mixed type. Okay, the myxopapillary, the clear cell, then the mixed type. Okay, myxopapillary, the clear cell, and the mixed type. For the meningiomas, okay, so the meningiomas are classified into four categories. Number one is the common meningothelial type, which is also referred to as the syncytial type. We have the fibroblastic, the angioblastic variant, and there are meningiomas which are of malignant type, although meningiomas are classically benign. So please take note of this. Common meningothelial or syncytial type, fibroblastic, and the angioblastic variant, then the malignant type. For the medulloblastomas, okay, before they were under the neuroectodermal origin tumors, okay. Now, we have the following: the neuroblastoma, retinoblastoma, and the ependymoblastoma. Now, what I want you to remember here, this is what always pops out in most board exams. For the neuroblastoma, okay, so let's put it here. For the neuroblastoma, you have to remember this is the most common adrenal medulla tumor in children. In adults, the most common adrenal medulla tumor is a pheochromocytoma. Now, very, very important is the neuroblastoma has the salt and pepper chromatin. Okay, so microscopic finding, the salt and pepper chromatin. Neuroblastomas usually present with an abdominal mass. Okay, usually presents as an abdominal mass in a child. So one of your differentials in abdominal mass in a child would be nephroblastoma or Wilms tumor. Now, the neuroblastoma microscopically, aside from having the salt and pepper chromatin, it has a very important microscopic finding wherein you see rosettes. And what is the name of these rosettes? We call them the Homer-Wright pseudorosettes. Memorize that. Then we have the retinoblastoma, which is actually considered to be the most common intraocular tumor, okay, in children. Early manifestations would be leukocoria, okay, which we call the cat's eye, leukocoria. If you read your Nelson's, which is your Bible for pediatrics, it mentions that aside from leukocoria, early manifestations can also be strabismus. Now, retinoblastoma usually presents as an intraocular tumor, microscopic pearl. If the neuroblastoma has the Homer-Wright pseudorosettes, a retinoblastoma microscopically would now have the Flexner, Wintersteiner rosettes. Okay, these are the things you'd bring with you to your exam. When you open your Robbins pathology, you're going to see this is there. When you open Harrison's, this is also there. So I hope you can take note of this. So we're going to end our session here. Thank you very much for listening.